This is going to cover some defects and disorders of your GU tract. So we're going to be looking at um, hypospadias, epispadias, testicular torsion, and a few others. So this is Cryptorchidism. I'm not going to be saying that right, but it's on the slide so you can see it. What it is an absence of at least one testicle from the scrotum. It's most common at birth. It's going to be with male genitalia. Some reason it's more common on the right side. It can be bilateral, but 2/3 of the occurrence are unilateral. Risk factors: low birth weight, family history, genetic predisposition. There is a link with autism. Complications: if it's not corrected or even with it, we can have decreased fertility, increased risk of cancer, testicular torsion is at high risk, development of inguinal hernia, and some psychological issues. Evaluation: physical examination identifies it about 70% of cases. We might use imaging for non-pliable testes, ultrasound sensitivity 45%. MRI is preferred over CAT scan. Sometimes we need to do hormone testing. Treatment is surgery, which is usually recommended between 6 to 18 months. Early surgery optimizes fertility. Hormone therapy for clients that also have Prader-Willi syndrome. Annual exams of testes, and then prompt treatment is crucial for fertility preservation. Follow up: yearly physical, monitor for cancer, assess for fertility, screen for associated conditions, and track developmental progress. Hypospadias. Um, this is when the urethral opening is located on the ventricle surface of the penis. Most common penile anomaly, and it can occur anywhere from the glans to the perineum. Associated conditions: we can have a partial or absence of foreskin, an inguinal hernia. Causes can be from hormonal influences in utero, environmental factors, genetic factors, advanced maternal age, low birth weight, prematurity. Epispadias is a dorsal urethral opening or an incomplete fusion. It's more rare. It can extend the entire length of the penis, and it may involve the bladder of the neck. Clinical impact: up to 75% of those patients have urinary incontinence. It's often associated with other bladder conditions. It may require stage surgical repairs, and it can affect sexual function. Therapeutic management. So hypospadias, surgical repair, 6 to 12 months of age. The goal is to straighten the penis during an erection, uniform urethral caliber, satisfactory cosmetic appearance, and minimal procedures is necessary. With Epispadias treatment, we do early surgical intervention is best recommended. It may require stage procedures due to the bladder involvement. So we might start with a bladder neck reconstruction, urethral repair, genitalia repair, then we might need pubic bone closure if needed. If a child with one of these, with the epispadias, is going to be going home after surgery, they're going to have a catheter, which would be a urinary drainage system. So when you're thinking about that, just think about all the catheter care that would be required for parent education. So now we're going to go on to the Hydrocele and all those guys. Hydrocele, Phimosis, testicular torsion, and the bladder. So hydrocele is an abnormal fluid collection between the layers of the testes. It's the membrane that surrounds the testes. It can cause significant enlargement of the scrotal sac. Could be congenital or it could be acquired. The congenital causes, it's common in newborns. It decreases to about 25 to 40% at age 2. Secondary could be due to infections, trauma, post-surgical complications, or even malignancies. Clinical presentation, it's usually asymptomatic. It varies in size. It's going to be tense, smooth scrotal mass. Diagnostic considerations, a physical examination. They can do transillumination of the testes, and they're going to see light behind the scrotum, which will distinguish between this being hernia or a solid mass. Careful evaluation is needed if it occurs in somebody who's older, because then we're concerned about testicular cancer. Treatment, surgery we can do, or we can just do conservative management for asymptomatic cases with just close monitoring. Phimosis. So this is tightness constriction of the foreskin around the head of the penis. It makes, if we like retract the foreskin and it stays retracted too long, it can become tight and constricted and almost difficult or impossible to put it back to its original location. It happens very commonly in children and babies. Causes could be poor hygiene that leads to the chronic inflammation. If they get a bacterial or yeast infection, that can get trapped under the foreskin, causing it to happen. In adults, it can be due to sexually transmitted infections. We can also have skin conditions like eczema or psoriasis or those lichen planus and sclerosis that can cause it to happen. So the clinical presentation, we're going to see edema, erythema, tenderness, purulent discharge. It's kind of painful. Complications, we can get inflammation of the penis head, foreskin inflammation, and risk for infection. Treatment options, sometimes we can do a corticosteroid cream 2 to 3 times a day. We could do antifungal medication if it's from that. Really encourage good hygiene. Sometimes we just have to do a circumcision or a dorsal slit surgery if it's starting to make the head of the penis become necrotic. Testicular torsion, this is considered a surgical emergency requiring immediate intervention. It typically happens in males under 20 years of age and is a twisting of the spermatic cord that supplies blood to the testes or the epididymis. Causes, it can be spontaneous in occurrence, it could be due to trauma, just anatomic abnormalities. The rotation is usually 90 to 180 degrees. So your clinical presentation of this is going to be severe sudden onset of scrotal pain, testicular tenderness and swelling. It's usually so painful that they're having nausea and vomiting. They could have a loss of normal anatomic landmarks due to the swelling down there. Usually pain is unrelieved even with rest and elevation. Diagnosis, we can do a Doppler ultrasound to assess for blood flow to the testes. If they have decreased or absent blood flow, that's going to confirm the diagnosis. Again, this is a surgical emergency. We need to restore blood supply within 4 to 6 hours. Sometimes they can do a manual detorsion where they can actually, a provider would do this, not a bedside nurse, but they can twist it and get it to resupply blood. If that doesn't work, then they need to go in for a surgical untwisting of the cord. Without treatment, the testicle will necrose and they'll have reduced fertility. Prognosis is good if it's treated within 4 to 6 hours. Poor if treatment is delayed. It may require complete removal of the affected testicle if necrosis occurs, and follow-up care and monitoring is needed after surgery. Okay, so this one is a rare congenital anomaly where the bladder herniates through the abdominal wall. Its exposed bladder mucosa appears very bright and red. The anatomical features is a open bony pelvis. It's unfused abdominal muscle at the anterior bladder. They have a separated pubic rami. They a divided clitoris in girls, Epispadias in boys, a waddling gait initially, but children will adapt. Clinical manifestations, you're going to see that exposed bladder mucosa, continuous urine seepage onto the abdominal wall, skin excoriation around the defect, painful, easy bleeding of those tissues, risks for cancer within first year. Treatment, surgical closure within 72 hours of life is ideal. Complete primary repair or stage procedures. So we do a bladder augmentation, a bladder neck reconstruction, and then they'll fall into epispadias repair. Management, we want to preserve renal function, achieve urinary control, prevent infection, improve sexual function. And this diagnosis is often detected through prenatal ultrasound. The next lecture will be on common GU disorders.